voltage
histologically
lesions?
Yeah, not really. I mean, as far as we can tell, they look very similar. Acutely, we don't see much. It is all electroporation. You don't see, I mean, because, well, I don't know anything about the waveforms, but it looks very similar to the other lesions. They behave very similarly.
All right.
I mean, we haven't done ultrastructural studies or things like that, but anyway.
All right. Thank you, Vivek,
thank you.
For this nice presentation. And next, it's our pleasure to show a live case of AFib ablation, enhanced workflow with nanosecond PFA and 360 conforming catheter. It's from Petr Neuzil's lab. Peter, I know how much your lab had to go through.
4 seconds, 4 slides. Okay.
Yeah. But before, I want to thank you for working on a Saturday. We really appreciate all your efforts. Thank you.
Okay, thank you. Okay, so so Vivek, I have 4 slides over there. Okay.
Yeah. No, absolutely.
So we are happy to show you, AFib ablation using the nanosecond pulse. Actually, it was the first nanosecond pulse technology we used ever. And it's like circumferential 360 degrees catheter. And hopefully, actually, we are lucky because 1 week ago, we just got approval for the sensor, which is implemented now. And actually, the technology is fully integrated with NAVEX. So the catheter itself is contained with 2 rings. There are 2 rings, like outer ring is 30 millimeters in diameter, and the inner is 22 millimeters. And actually, the ablation energy is going through bipolar through this. And actually, the ablation energy is like volumetric. And what is interesting on the nanopulse technology is you can easily get much deeper lesion. And what I need to say that actually we are very familiar with microseconds and nanoseconds. So actually in the nanoseconds pulse is going like over 100 or whatever 1,000 volts. It's like really crazy. So let's go forward. So the catheter.
Wait, sorry, Peter. Just to make it, it's not over 100,000 volts. It's over 10,000.
Okay, so crazy.
Just in case.
Crazy energy. And actually, it's interesting because with this kind of energy, you can minimize the number of applications which are very critical. And per vein, we are hoping to use just like only 2 applications. Actually, you can see this mushroom pulse in the PV. Actually, Honza, Petru, and Toshi are doing the case, so they will show you, I hope, live. And what is interesting, and I mentioned that the catheter itself has like 12 electrodes for mapping and for localization, but the sensor now is implemented, so we can actually use the NAVEX to project the lesion. So actually, we are happy to see where we are ablating. So the targeting the lesions, okay, exactly. Let me finish, okay?
Peter, do you want to just talk about, so these are the electrodes on each spline?
It's interesting to mention. Actually, these electrodes, like these 5 electrodes on the ring, indicates the impedance. So by impedance, you can visualize the level of contact. These spines will be, maybe Honza will show you during the case. So when you are in optimal contact, the NAVEX indicated to you the blue. And actually, if it's white, it's like off contact, okay? So I think they have a space to show.
It allows you both contact sensing capability as well as electrograms.
Okay. So guys, so we are open to, okay, so actually, can we connect? Oh, it's later. Switch up, okay. Okay, guys, we see you. Okay, Honza, Toshi, are you ready?
See us, do you hear us?
Yep,
yes.
we can.
Hey, hi, morning. Hello.
Happy
My name is
team.
Petru. Toshi Funasako is here with me. So thanks, Peter, for introduction of the technology in theory, and we would like to show it in practice. So, it's still not, this system is still not commercially available, so the patient is included in the clinical trial. So the patient is number 97. So we have, I think, a lot of experience right now, but we are still learning. And this is what is new is definitely the integration with the Abbott system. And this is what we like to show you. The workflow with the catheter and also together with the integration. The patient on the table, let me introduce a little bit the history of this patient. He is the male, 57 years old, with atrial fibrillation history about 3 years. He is on xarelto and propafenone and beta blockers. Left atrium, it's a little bit enlarged, like 42 millimeters, normal ejection fraction. So the plan here, how far we are now, so the patient is in GA, so he is relaxed. What we have done so far, we have introduced 3 catheters into heart. You see maybe on X-ray there is CS catheter. We did transseptal puncture with RF wire directly with the Agilis 13 French sheath, because the catheter itself is 11.5, so we need a little bit bigger and larger sheath.
Yeah, Honza, Vivek, just to clarify, so this is the ID 13 French Agilis sheath.
Yes.
The 17
yes,
is OD. Yeah, go ahead.
Yeah, thank you. And there is also additional catheter, which is intracardiac echo for like navigation and manipulation. So we have done also the map. You see it. We used AG Grid X. It means that the map is very, very stable now, and I think it's good prevention of any shifts. So we are almost ready. You see how the catheter, the epicenter catheter, is inside left atrium. You see all splines, you see all rings. And Toshi, we decided to share a little bit the procedure, so Toshi will start on left side and I will finish right side. So maybe Toshi, if you want to continue.
Yes.
And last thing, sorry. So the workflow is to put the catheter inside the vein into the ostium. It's like an osteal lesion, and then withdraw a little bit to do the antral lesion. And then, if we are not satisfied with level of isolation, we can maybe render a little bit around atrium, around antrum, and to finish some other lesions. So, thank you, Toshi.
Yeah. Please look at the X-ray and the 3D mapping system. Where we have the flipped mushroom shape right there. Push on the wall and reshape like mushroom and go inside the vein.
Notice, by the way, how the splines... Oh, go ahead, Toshi.
Oh, sorry. You see the splines are highlighted partially, posteriorly, and then rotate the catheter to get more better contact. Okay, shallow, please. That we are inside the vein. This is osteal position. Number one.
Notice, by the way, that it's turning blue, that segment. So if the mini electrodes are touching tissue based on electrical impedance, then that segment in between turns blue. It's not perfect, but it does give you some general idea of where you are. It also, I think, is important that. Sorry, go ahead, Toshi.
Yes. Let's go. Pulse.
Actually, are you using 5 seconds pulse? Because we can use like 2.5 and 5 second pulse. Okay, so 5. Okay.
Yeah, this is 5-second application, and this is because of our clinical experience in the study that if you use 5 seconds of application, we have more durable data than with 2.5. So finally, we use just 5 seconds.
Good point.
Application.
Yeah, I should just caution. The data that we presented yesterday with the 5-second versus 2.5 was really using minimal electron-anatomical mapping. We didn't have this kind of navigation. This literally started like a week and a half ago. I mean, I think Andrea actually did the first cases with this in Italy. We did cases like the day or two after. So I think we do need to look at that question again. Now that we have better navigation, maybe you can even do 2.5-second pulses. Notice, by the way, the blue splotches, that represents the intersection of where the field should be with the surface. And when I say the field, I mean really it's just the intersection of the shadow. How big should the field actually be? That kind of additional modeling can eventually be incorporated, but is not currently.
But Vivek, actually, when we integrated with Navex, I think that we are able to minimize the lesions, right?
I think so. I mean, we'll have to see. So your strategy. So you did an osteal and an antral lesion in each vein, and what are you doing now?
We just finished 4 PF applications, 2 each on the superior and the inferior. And look at blue shadow on the 3D mapping system that's called field tag, where we can see the, yes, right there.
You have good contact right now.
Yeah, good contact on the posterior wall. I'm going to add one more region here. Let's go. Shadow pulse, please.
And notice, I mean, anteriorly, it may be that some of those splines are floating in space, as you'd expect.
Yeah.
But that's okay.
Right.
Honzo, can I ask you? Actually, are you worried about Honzo? Are you worried about the narrow corridor on the posterior wall when you are so close on the posterior wall?
Of course, you should be like there is some concern. Definitely, if you don't have the like mapping system. So if you can do this isolation just with intracardiac echo or X-ray, but you don't see what you are doing on posterior wall. So if you have this mapping system, mapping tools, then you can be like easygoing with the level of isolation.
Because the width of the lesion is really like significant, like over 10 millimeters.
Devi, sorry, 1 second. Devi, you have a question or comment?
Yeah, so yesterday you were talking about how it's got a toroidal lesion, and so when you're doing these, does the E-field actually give you that? Does it give you a center that's not?
Nice contact.
Yeah. So, you know, the slide that we saw before, the very first slide that Peter showed, you can see the energy is delivered between the inner ring and the outer ring. So the lesion, the pulsed electric field, the ablative field, is not a disc. It's a toroid.
Like donut.
Like a ring. What's that?
Like donut.
Like a donut. Yeah, it's a donut of electrical field. That also means that if you're not centered, that the center part of it is not ablative, currently, at least. So you want to make sure that the center, that you're relatively coaxial, relatively centered within the vein. What's interesting is, you know, when we first started doing these procedures, we didn't have this kind of navigation. I mean, the ablation was basically based on ice and fluoro. And I was actually stunned that despite just that, we had really quite good durability in the initial studies. So there's a lot of forgiveness here, but still I think that having the mapping, that, you know, they're spending time really making sure that you're as coaxial as you can with the long axis of the vein.
Ablation.
And if there are questions, please do come up.
So how many lesions you want to go for the right upper?
So we did just 2 right now. So now my plan is to go maybe for inferior vein, and then we will see what is the shadowing
we'll
after pauses, and maybe we can finish on carina. So let's go for inferior vein.
Yeah, we have
the same workflow.
We have a question here, Matthias.
I have a question. You're all experienced users. How would you assess the similarities and differences with Farawave procedures? It looks very much like a Farawave, so what are the similarities, what are the differences?
The differences between this and Farawave, yeah. So one of the things you notice is that the ring sort of connects these various splines. So it can't, yes, it's very supple, which is one of the advantages. It can bend back, you can push it inside the vein, etc. But it's not like the splines are going to get closer or further apart. They're fixed because of this. Now, sometimes if you push it so far in and the thing folds back on itself, then it won't deliver a pulse, okay? But in general, the electrodes stay apart from each other, and you're able to deliver a very homogeneous lesion. By the way, you have to. If you have unpredictability in terms of where the electrodes are close to each other or further from each other, you could end up delivering, I mean, you're delivering 10,000 plus volts, so you could end up doing all kinds of damage. So that's one thing that's different. There are a lot of similarities. You know, with the Farawave catheter, you can go from a basket to a flat. And I don't know what exactly Honza is planning in this case, but you could put this on the posterior wall to do posterior wall ablation. We've done a lot of that. You can also, interestingly, you can map with this, and one of the, I guess, differences is with the current Farawave catheter, obviously the electrodes are very big and far apart. Here you have bipoles that are small, relatively closely spaced, and I imagine they're going to end up doing a voltage map after this, so we'll take a look and see what that looks like.
Vivek, but also the workflow is very different than Farapulse in terms of
that's it.
The workflow is completely it's like one application. You don't have to
I mean, this is it creates very dense lesions or electrical field enhanced lesions. So you notice that there's not a lot of redundancy at the location. It's a single lesion.
So
Obviously, you don't need to rotate. There's no reason for that. So they delivered an ostial and an antral lesion in each vein, and then a little bit anteriorly.
Okay. Is this the last lesion now?
Yeah, I'm just thinking about a little bit, maybe go a little bit to inferior vein.
Okay.
But I think if you look, maybe the level of isolation is okay for us.
Yeah. Okay.
You can think of it, but I think it's okay. Can you rotate with the map?
I would stay more on the anterior
Can you
part.
There's a question here or comment, Ed?
Yeah, beautiful case.
Okay.
I guess you mentioned, Peter, that one of the advantages of nanosecond is lack of skeletal muscle stimulation. So why GA for this case? Why not do it with conscious sedation?
Actually, GA for a live case, we are using because they need to be more quiet, okay? They are a little bit nervous, guys. And usually, we need to consider that we just opened the study a week ago, and actually I am a little bit afraid about movement, the navex and shift and whatever. Okay, so this is the reason. But actually, in terms of musculature irritation, it's a very good point. And actually, with nanosecond pulse, we really see in our cohort of patients in Homolka, which are close to 100, so we cannot see too much musculature irritation. I am not sure about coughing, but I cannot tell that. But musculature irritation, like the jumping, it's minimized.
I mean, one thing
that would be a big advantage.
Yeah,
in the work.
one thing is this is bipolar delivery, right? So the field is very dense around the electrode, but you don't have too many far field effects. And one important point, Peter briefly mentioned, we have done cases just with deep sedation. In fact, we've done a lot of cases with deep sedation. So, what's the durability of deep sedation versus general anesthesia? All these questions need to be worked out. But certainly we've done it, it can be done.
And actually, I will mention one aspect. Okay. So we really want to be in full contact. This NAVEX visualization is perfect to get really good contact, because when we have no good contact, we can have a risk of hemolysis. So I think this is good protection to get lessen hemolysis and minimize the number of applications. Okay, you are showing the catheter. Okay, fine, fantastic.
Go ahead, Honza.
So you see now we exchanged the catheters. Now we are doing the map, like remap, just to confirm the level of isolation and isolation of all veins. So I'm finishing now. I did left superior and left inferior veins on their posterior parts. Now I'm going to right veins to try to get there.
Actually, I think that Vivek mentioned that. Show us the catheter. So when the two rings, Honzo, can you show us the catheter again?
Of course.
So
do you want to?
Okay, no, just show it. Okay, I need to comment. So the outer and inner ring, when it's collapsed and actually touching each other, that it's arcing. So this, it's an issue how to protect, false application or bad application. Okay.
Can you, well, you're going to do a map right now, but certainly you can also put this against the posterior wall. We have done CT isthmus lines also with this catheter, obviously giving nitroglycerin pretreatment. And you can certainly get a CT isthmus block with this very easily. It's a big lesion. It's a very wide lesion. I wouldn't call this the most elegant tool for CT isthmus lines, though.
Vivek, is there any role in being able to select certain panels or how we call it?
Right now the circle is a single electrode, so you have to deliver between inner and outer. I know that the company has a next generation catheter that that's going to undergo preclinical testing and hopefully clinical testing, where there's going to be a central ablative electrode where the catheter, the shaft is. So then what that would allow is, instead of a toroid, you can get a disc-like lesion. Or you could deliver a lesion, for example, between the center and the inner ring. So it's a more focal type of application.
A very simple-minded question here. So the very first slide Peter showed, the proposed electrical field is this even donut shape. But if you look at the electrodes, the bipoles are closely spaced, but each spline has large spacing. So how do you know that there's not a fall-off in between the splines?
I'm sorry, I'm not sure.
Yeah, so if you look at the picture of the electrode, the splines have quite a larger distance between them, the two electrodes, as opposed to the two electrodes on each spline. So how do you know that there is a even distribution of electrical field across
Well,
the
again,
entire
just to be
donut?
clear, the small electrodes are not ablative at all, right? Those are only for recording. The only ablative, the energy is only delivered between the outer ring and the inner ring. And because the splines are relatively fixed, it's hard to bring those together. The ablative splines will just sort of, they'll tend to keep them relatively similar.
Yeah, 'cause the practical question I have then is, and so you have found that there's no need to deliver multiple lesions across. You just do one lesion, and then
I think he was talking about the outer circle, the inner circle. The distance on the catheter is large, so how do we know that there is no gap? But
right.
we haven't seen it.
So if you go in the vein,
between the outer and the inner, you mean?
Yeah, that's what he was talking about.
The spacing, if you go like deeper in the vein, it's going to be a closer spacing versus if you're natural.
Oh, I see. Yeah, but the thing is, the distance between the outer and inner ring is still relatively similar. Yes, the morphology gets bent backwards, but it's still similar distance between the two rings. You see what I'm saying? I understand your question now. Yeah, it makes a lot of sense. But it's still the distance. Yes, they may spread a little bit, but we're talking millimeters here. It's not like, dramatic differences. And just empirically, again, we don't need to do multiple applications. The other thing you notice, by the way, is, and I don't know if you can show, once they finish this, we should look at the shadows of the electrical field applications and look at the locations of those relative to the low voltage. But again, because it's bipolar, it tends to be reasonably tight. At least that's our observation after the 3 cases.
Hanzo,
Yes.
can you comment the map? Actually, Musa is commenting that actually you can do second case now. You have still time, 9 minutes.
Okay. Of course we can do it in different lab.
Okay.
So
can you comment the
we are
map?
done, I think.
David?
I think it's done. So if you can rotate and to show, and also you can appreciate like voltage reduction in electroanatomic map and also shadowing, which is like almost the same. So you can believe that the navigation shows you where you really putting, where you have the contact, and also where the voltage reduction finally is. So you see,
like the
you can
posterior
create a
walls,
line.
Great.
Yeah. And there is no any corridor on posterior line, so maybe we could be even like more aggressive for ablation. But this is paroxysmal AFib patient, so I think that this level of isolation is good for this patient.
Devi, you want to make a comment or question?
Honza, this is Devi. Hey,
hello.
the first map that you had, was it made by the catheter or was it a grid map?
It was HD grid map.
Yeah.
So of course you can map
But
it.
this is a good question. Actually, David, it's a good question. Also, can you just try in the meantime? Do you think that we can map with the 360 catheter?
Yeah. Why not? We can do it. Yeah.
So actually, Andrea, you want to just talk for a minute about that? So you've done a couple of cases, I think, using the grid catheter to make the map. Can you just comment on what that experience was like? Not the grid, I'm sorry, using the ablation catheter.
The ablation, yeah. So you can generate the map with the ablation catheter. It's not as nice as you see, in this case today where it was done with the HG, but you can actually do that. I think it's something that is going to evolve, but you can do the map with the ablation catheter. So we've done a couple of cases like that.
Yeah. Pierre?
Thanks. Great case. Amazingly fast. I was wondering, so you are remapping, is it systematically done? And is it needed? In other words,
can you
have acute remapping showing persistence of connection in some instances, or is it never observed?
No. So all the cases we are remapping using a mapping system, electroanatomical mapping system. And this is part of a clinical trial where we do remapping also. And I mean, we're not getting 100% of the patients come back, but we're getting 80+% of the patients come back. And yes, acutely we get isolation. I mean, maybe there was a case or two where we didn't have to do another lesion, but I mean, over 95%, you have isolation after the first set of lesions. And then in terms of durability, well, I showed the data the other day, we're over 90%. Now, it'll be interesting, now that we have good localization, will we get even closer to 100%? Be a good question.
Yeah, probably. And did you notice those persisting activities in the vein with the ablation catheter before you remapped, or you have to remap to see them? You have electrodes on the spine.
Yeah. No. You certainly see electrodes before you ablate, but once you ablate it, they're gone. It's completely wiped out. Was that your question?
I mean, you said that maybe on a couple of occasions you had persistence of venous potentials after ablation that were detected during acute remapping.
Oh, I see.
Was it visible with the ablation catheter?
Yeah, it's a good question. We have not looked at that systematically. There are so few cases that I can't even comment on that. But look, these are small electrodes, so I would imagine that we should be reasonably comfortable that if there's persistent potentials, you could determine it with this catheter and not having to open another one. I think that's your point, yeah.
I think the quality of the recording are pretty good actually from the ablation catheter. You get sharp recording.
Sharp electrical. Yeah, absolutely.
Vivek, is the reason for the grid just a part of the study? Because this looks pretty good. I mean, why was the grid even open to?
Well, yeah. Okay. Again, just to be clear, right now they're using the grid anatomy and creating a map here. So the question of the anatomy created by this, that's what Andrea has done a couple of cases, and as he said, it's not quite as good quality, but you can do it. That's something, look, you have to understand, it's only been like a week old that we've had this integration. So we do need to do that. My guess is that we will be able to do it. It won't be certainly as good as a grid anatomy because that's higher density of electrograms. But the fact that now, we have a magnetic sensor, it opens up a couple of different possibilities.
Can you pace? Can you pace from this catheter?
Yeah, we can actually. We've had a couple of cases recently actually where the patient went into an atypical flutter, and we created a map using this technology, and certainly you can do entrainments and things like that. Yeah, that's not a problem. Yeah. Shaif, were you about to say something?
No, I wasn't. But Hansa, while you're here, can you remind us your total applications that you gave?
So finally, there was 13 applications. So it's like. Typical for this kind of ablation. So in the study, it was about 12 to 13 applications per vein. So
no, not per vein, per patient.
Case.
Per patient.
Yeah, sorry. Yeah, for all veins. Yeah, that's it. Maybe if we have time, we can show you one remap we did like yesterday or previously. So you see on the left side there is the index map during the first procedure, and on the right side is the same patient and remap, and you see the consistency of lesion set. There is no any regression, and veins are really isolated. And I would like to also mention, Vivek spoke about the atypical flutter ablation, and also we did yesterday additional remap, and there was a patient with anterior lesion on left atrium because of atypical flutter and a lot of scarring on anterior wall, and we did the line there, and there was still no contact. There was still block. So even maybe for lines, not just pulmonary veins, you can use this catheter, but definitely we need more data.
Hansa, be aware, Vivek doesn't like the anterior lines, okay?
I know, but he did it. Okay.
Yeah, any other questions? So, Hansa, you have about 2 minutes left. So, do you want to just comment about what it's like to try to position this in the CT isthmus, and what's the strategy you use?
Yeah, maybe we can show it quickly.
Yeah, you can pull back to the right atrium and position.
The catheter is not deflectable right now, so you need to use a lot of sheeting. So we normally use the navigation with X-ray and also intracardiac echo, and you put the catheter and deflect just on the cavo-tricuspid isthmus. How we do it also with penile spine catheter. So you see, it's definitely better to go more lateral than ostial, just to avoid the proximity to AV node. But I think this is reasonable how you can do the lesion on the cavo-tricuspid isthmus. I would say in this position, if you see it right now, you can do maybe 2 applications to get all the cavo-tricuspid isthmus.
2 positions. Yeah.
I mean, it's actually a pretty good localization, given that you didn't really create a dense electrical field with the grid catheter in the right atrium. It's not bad, actually.
So we can do it, but we don't want to do it. In this patient, there is no flutter, so it's possible, I think. Yeah.
Yeah.
And of course, we have to mention about the risk of coronary spasms. So in case you do it with PF energy, then nitrates are really appreciated. And this is our strategy.
Yeah, and I just should comment again, just as we were talking earlier about field medical technology, also high voltage, I think we still need to understand exactly what is the proper nitroglycerin dose that we'd want to use. So those studies really do need to be done at some point. Currently, we use the same strategy, 3 milligrams, 222. So, Honza, we're down to the last 41 seconds.
Yeah.
Any final comments you'd like to make?
Yeah, okay. Thank you. We are very proud to be part of this symposium. Thanks, Toshi. Thanks the company and everybody here. And I think that you appreciated the workflow and ease of use with this catheter and also with the integration with the mapping system. I think, of course, we need some more data. We need to get more experience. But until now, I think this is the fastest application and creation of durable lesion just with one application, 5 seconds. So we will see the future. It's open, definitely, but I think it has really big chance to get to the for commercial.
Okay. Thank you so much, Honza. Thanks, Toshi. Thanks, everyone. Thanks, team.
Thank you.
Thanks, Peter.